Hello, I'm Dr. Gary Wörtz, and I am really excited to be talking to you tonight about a new initiative called Interventional Mindset. I'm joined by fellow creators, Dr. Preeya Gupta and Dr. Nathan Radcliffe. And today we're going to be talking about what does it mean to have an interventional mindset as an ophthalmologist. I mean, I got into ophthalmology because I wanted to fix things. And I saw with cataract surgery and other procedures, I was amazed that a short, simple, or at least what looked to be simple procedure could have such a profound impact on someone for the rest of their life. And that's really what drew me into ophthalmology. It was really that idea of having an interventional mindset. And today we're going to be talking about how do we gain momentum when we're trying new procedures? What are the barriers and hangups that prevent us from getting started? And how can we be successful as we try to move our practice forward? So with that, Preeya and Nathan, thank you so much for helping, I guess, all of us creating this together. Preeya really is the one that we should be thanking most. This is really her brainchild. But Preeya, tell us a little bit about why you thought this was so important to get started and what was the genesis of the idea?
Thanks, Gary. Like you, one of the things I love about ophthalmology is the variety and also just the intense technical nature of things. We have access to so much technology. And, when I look back at my own practice, I've been in practice for almost 10 years now. When I first started out, I finished fellowship and I was like, okay, I know everything I need to know. I'm going to go 100 miles an hour and I'm going to be able to, cruise and be my best cataract and refractive surgeon self. And, within I think it was 18 months, there was new IOLs, new lasers, new everything. And, for someone that was kind of feeling like on top of the world, you're often you have mixed feelings about new technology. And definitely, I have relied on my peers and colleagues and kind of bounced ideas on, okay, what do you think about this technology? What do you think about that? But really, I think there's some significant hurdles for, when we go to a big meeting and hear about this new technology, it's not so seamless to know how to integrate that back into your own practice, make it your own. And, that's really, I think, what this idea, this concept is all about, is to help bridge that gap.
And Nate, you are our resident glaucomologist. All you're doing is intervening. You're punching holes in eyes. So what does interventional mindset mean to you?
Yeah, Gary and Preeya, I couldn't agree more, and it's great to be part of this. Luckily for me, my field really entered a renaissance right as I finished my training. And, as we all know, the eye stent sort of invoked the beginning of MIGS for glaucoma, and we've been on a roll since then. So to keep on top of the technology, I have been learning new things, at each moment. And, this has required sort of daily, if not, weekly education. We're always bringing new things into the operating room. At the same time, I see some of my other skills sort of taking a back seat to glaucoma. I'm embarrassed to say I was the first surgeon to put a toric lens in the Manhattan VA, but I haven't done many toric lenses in the past 6 months. And so I'm interested in this process of, how you can be at the top of your game in one area, feel very comfortable intervening. But what about the other areas? Is it really just the same process? What do we need to know to be sort of the best interventional version of ourselves?
Yeah, and this project really encompasses 3 spheres. One sphere is glaucoma, one is ocular surface disease, and one is refractive cataract surgery. And what I love about the way, Preeya, you've organized this is that really these things are all overlapping. If you're a cataract surgeon, you have to deal with ocular surface disease, and now you have an opportunity at least to deal with cataract or with glaucoma patients during cataract surgery in very meaningful ways. And it seems like in the past, it was okay to be in a silo where you're like, well, I'm a glaucoma surgeon and I do cataracts too, but I'm mainly a glaucoma surgeon, or I'm a cataract guy. And, I don't really deal with ocular surface disease because, that's for someone else. And if it's glaucoma, I'll just send them for a trab once they get too bad. And, if you're an ocular surface, that might mean you're a medical ophthalmologist or you're an optometrist primarily dealing with that one disease process. But it's very interesting that, I think the next generation of anterior segment surgeon, if you're really going to be at the top of your game, you have to be willing to really tackle all three of these things. And if you're not doing all three of them, I don't know if you're really doing yourself or your patients, a true service, in terms of what the technology brings. And I'm being hypocritical here because I love doing cataract surgery. And even though for about 3 to 4 years, I was very deeply involved with dry eye, and glaucoma, I think the technology is great. I've just not really engaged to the level that I probably should. And so I'm so interested in this process, not only to give advice about the areas that I've really learned to move and gain momentum to try new technology, but also to learn from you all about ways that I can get my practice going in that direction, because I do want to learn. I want to advance, but there's a little bit of fear that maybe I don't do it right, or maybe I'm not really good enough to do the advanced stents that Nate Radcliffe is doing, or maybe I just don't have all the stuff set up like Preeya does at Duke for ocular surface disease. So Preeya, do you see barriers like this in your practice, or that maybe hold other people back from really setting out to fix things that we can fix?
100%, Gary. I think that first and foremost, at least for me, the thing that holds me back sometimes is wanting to do something perfect from the get-go. We set such high expectations for ourselves, and sometimes we don't have all the resources we need. When you adopt a new technology, you kind of need someone there to hold your hand, to walk you through any troubleshooting. And when you're in practice, especially if you've had a lot of experience, the learning curve can be pretty quick. But those first few cases, those first few conversations with patients, those are where I think that's often where I feel like I need help. I need help getting the experience, and I need help gaining the confidence, because I've seen it unfold for myself with a lot of technologies. I was a little bit late to adopt femto. I've only been using it for maybe the last 4 years or so. And in the beginning, it was something that I offered my patients as an option. And as I look back, I can see myself talking to patients and not really being confident in the technology. And when we communicate with people, our patients in particular, they'll know and they'll sense whether or not you believe in something. And over time, as I've gotten to use the laser, I probably use the femtosecond laser in 75% of my cataract surgeries. I've become such a believer in the technology because it has helped me really prioritize astigmatism correction in refractive cataract surgery. And I've used it in complex cases, and just really found many uses and great utility. And that's just me in my own practice. And so I think that first and foremost, kind of surrounding yourself with some tools and some friends or colleagues that have experience is a great first way to start.
Yeah, I think my pitch for femto in the beginning was like, there's this laser, and it can help me with cataract surgery, but I'm really good, but the laser's good too, and it can do some things that I can't, but you'll be fine if I do it. But the laser is a laser, and that is something you might really like, but you would also probably just like it the same if I did it. Like, who is going to sign up for that? Like, that's not so of course my penetration was not very high in the beginning, but like you said, Preeya, like over time you realize, okay, there are some real benefits. And then when your confidence starts to build, guess what? That enthusiasm is contagious. And you talk to your patients about, we can do this standard, it's fine, but I would love to use a laser for reasons X, Y, and Z. And, it will be fine either way, but I feel like it's good or great. We don't have a bad option, but, in your situation, I think you're going to see better. I think you'll potentially heal faster, might use less phaco energy, et cetera. And the precision is really fantastic. So for me now, I have no problem talking to someone very honestly about femto, because I have got thousands of cases to back up what I'm saying, but it is really hard at the beginning. Nathan, what do you think about starting off, the things that are in the back of your mind that maybe prevent you from really getting started?
I mean, all these themes are the same. And this is what I love about this conversation is, the theme for barriers for the glaucoma specialist thinking about doing, multifocal IOLs is really the same as for others. When I think about what made learning glaucoma and interventional mindset easy for me, it was that I know at the end of the day, I can handle the toughest glaucoma cases. So the confidence I could bring to an early intervention with a safe, MIGS type or laser surgery, I could present that confidence so well. But at the end of the day, I don't do LASIK. And what I have learned is that the most important thing about getting a multifocal IOL patient to be very happy is nailing the target. And so that little voice in the back of my head that says, Nate, you're probably not going to do LASIK if this patient doesn't, get the result you want. Do you have a plan for that patient? What are you going to do if they're unhappy? And I think ultimately that sort of brings me to a place where my consent process is, you have to be highly motivated in my office to make it through my consent, because I don't make too many promises. But unfortunately, that also comes through maybe to patients as either a lack of confidence in the technology or possibly even a lack of confidence that, I can fix their problem. Yeah, so these barriers are, they're sort of similar in all these different arenas.
So for me, I was sort of early on the multifocal train. Like in 2008, when I finished training, Restore had just come out, and some of my mentors in training were doing Restore. And so I thought, okay, well, I can do it now. And again, it was similar. I didn't have access to an excimer, but I tried and really got frustrated with some of the earlier, generation multifocals. And, they were as good as we had at the time, but I was probably not in the right mindset personally, or didn't have enough experience dealing with complications. Or what if I've got to do an explant? What if I've got to do refractive surgery? How am I going to handle that? Do I send them to another surgeon? I mean, there's so many layers of uncertainty that really, I was pretty quick to back off because I just wasn't achieving the results that I wanted. Fast forward to when the low-ad Tecnis multifocal came out, followed by Symphony Toric, and now Panoptix. I mean, I am just so excited when I get the chance and opportunity to talk to someone about total vision correction. That's kind of how I talk to patients now. I don't talk about, do you want to see here or there? People want their total vision restored. And because I've had to do explants for other surgeons and also for myself, I mean, it happens from time to time. You need to, be able to do, an explant. Now it just doesn't bother me. So I just say, they say, well, doc, what if I don't like it? And I say, well, I'll take it out. It's not really that big of a problem. Well, what if what if I still don't see very well? Well, we'll just do LASIK. I mean, I can walk right over and do LASIK. I do it all the time. So it honestly is having additional tools and also a different level of confidence with some skills that you might have built along the way that really allows you to no longer see those mountains as unscalable, I guess. Preeya, give me an example of something. You talked about femto. What was it in your practice that either made you decide to use femto, or when did you start getting really excited about it?
I would say for me, I started to notice that patients were actually seeing better uncorrected when I was using the femto. And, after enough cases, after enough post-ops, you just kind of catch on to the trend. And I would say that, one other thing that I don't think we've really touched on, something that always used to get under my skin a little bit and make me a little timid about new technology is talking to patients about out-of-pocket costs. And I used to have the mindset that if I asked someone to pay for something out of pocket, that it was okay if their expectations, went through the roof. And that if I didn't deliver their level of expectation, but not just what I knew the technology could do or what I could deliver, that it would be considered a failure. And so for me, and I do refractive surgery as well. And I also do a lot of ocular surface procedures that are also out of pocket. And so, maybe it was the collective, hey, I'm going to become comfortable with this or I'm not. But I found that, setting realistic expectations for the patient is something that we talk about it a lot, but it's there's actually an art to that conversation, and there's an art to being okay with yourself and telling the patient that this is what you can expect and these are the limitations, and sort of allowing the patient to make that informed decision, as opposed to taking the weight of their sort of demands and requests onto your own shoulders. And I think that that is something time and time again, when I talk to colleagues, especially for things that are out of pocket costs, if they say, well, what if they're unhappy? Do I give them their money back? What if they're unhappy? Do I, how do I deal with that? And I think that, we're doctors. We're not salespeople. We're not used to talking to patients. We're not used to mixing the financial and the medical transaction. And I don't think that they should be mixed. If you believe in a technology, if you believe in an outcome, if you believe in a treatment pattern, then that's what should be expressed to the patient. And similarly, you should be, if you believe in the technology, whatever it is that you're choosing, you should be able to talk to any patient about it and not worry about, are they going to be able to afford it? Or is it something that, that you should selectively introduce? I think that's really, for me, something that sort of changed my practice is when I sort of stopped worrying about the cost of things and simply presenting it to the patient, because it's not my fault that something's not covered by insurance. That's just our system. And so, allowing the patient to have the control and power to make that decision made me more comfortable talking about it.
Yeah, I also think that, if we were dentists and we were doing crowns all day, we would just say, you need a crown. It's $5,000. Your insurance doesn't cover it. And do you want your tooth fixed or not? And it's not like, well, I'm sorry, like we can submit it and then like we can write you a letter and then you might get it covered. And, they're just like, no, like you have to pay. And this is, if you want your tooth fixed, this is what it's going to cost. And I do feel like since we are in this weird world of like refractive and insurance based, that we are always doing that dance between, well, this part's covered, this part's not covered, this choice is covered, this choice is better, this is what you should get, this is what you could get. And it's sort of like at some point, the complexity of it, I think, makes some people just want to back away from it. Nate, I'd love to know, speaking of complexity and maybe paradox of choice, with all of the MIGS devices that are coming out and have come out over the past, 4 years or so, how do you assess something as, okay, this is something I'm excited about, this is something that looks like it's going to have merit? Because for me, looking at trabectome versus Sight Science Omni versus, Cahook dual blade or iStent inject or Hydrus or all the other various things we can do. I think I even missed one. I think there's multiple ones I missed, but there's so many things happening right now in MIGS. I'm almost paralyzed by, well, I don't know what I should do. Does any of this work? Does all of it work? Does it just work for some patients? I feel like I'm just drowning in MIGS. So how do you figure out what you want to do?
Yeah, well, what's the saying? Anytime you have multiple ways of solving a problem, either all of them work or none of them work. And I think the dilemma with MIGS is an embarrassment of riches in terms of choices. And this is one of those things where someone who's not that involved with MIGS may think that there's a wrong choice here or there. And the reality is they all broadly have the same indication. They all can be used in any situation that MIGS can be used, and by that I mean if you have an open angle and the patient has glaucoma or even ocular hypertension. And so, I see it as lots of choices, but no wrong choices. But it's a great example of, and I also think that what works for some doctors is going to not be the same for other doctors. So for me, I'm very open to using all of them, and that is where I like that we have all these industry partners, because I think you want to let someone in your office and let them take the time to educate you. And what's great is there's a lot of competition, but that means a lot of reps and a lot of industry willing to hold your hand. They're willing to come to your operating room 10 times in a row, and until everybody's happy. And, that was one of the things that if you're learning on your own and you're finished your training and, you aren't in an academic setting, you're going to have to learn by, partnering up with industry. unless you're really fortunate and you can have talented colleagues come to your OR, or maybe you have the travel flexibility to watch other surgeons. Something I want to do more of, by the way, over the next 5 years. But we have these industry partners you can lean on, and they're really serving an important, an important role in this MIGS evolution.
Yeah, one other thing I want to talk about, and Preeya, you sort of brought this up when you were talking in the intro, is being a lifetime learner. The idea that when we're in residency, a lot of our habits of what we do are based on what our mentors did. I mean, I still do my capsulorhexis because Seema Kapoor, showed me how to do a capsulorhexis, and that's just, to me, the gospel. I can't do a rhexis the other way or any other way, right? And, I think I still have these inborn things in me that were, kind of beaten into me for a good reason in residency. I don't know if there's necessarily a plan that we give people once they're out of residency to continue to evolve their skill set. I mean, I think, we have to give credit to Academy, to AAO, to the ASCRS, and other, groups that do skills transfer courses, wet labs, et cetera. But, I feel like it's really just kind of left up to the individual in terms of what they want to do. And it's very scary trying to learn some of these things when you don't have your mentor from residency sitting next to you, sort of walking you through it step by step. Like Nate, to your point about LASIK, I mean, I was fortunate to join my partner, Lance Ferguson. And for the first 6 months I was with him, I basically did all of our refractive surgery cases with him sitting right next to me. And, I did 30 LASIK cases today, no problem whatsoever. It's just super easy. It didn't raise my blood pressure. But like, if I hadn't had those 6 months, 5 years ago, with him sitting down next to me, showing me the ropes, I might still be in the situation of, LASIK, I don't know if I really want to do that. How do I do it? No one wants to train anyone else how to do LASIK, especially in their own market, right? Because then we're training our competition. So Preeya, what do you think about, how do we educate ourselves and each other in ways that are not just theoretical? Because a lot of the lectures are, oh, in theory, you should do this, but like really getting down to the nuts and bolts of how you go through, whether it's hiring staff or refractive coordinator or, all the nuts and bolts. I mean, isn't that kind of what interventional mindset is trying to get to the bottom of?
Absolutely. I mean, it's bridging the gap, right? Taking what you learned at a course or at ASCRS, AAO, and bringing it back to your office, to your staff. And, I look at so I do, cornea work as well. And within less than a year after I finished fellowship, DMEC came out. And I was like, wait, seriously? I just learned how to do DSEC. And, I watched videos, and there was a little manual that Mark Terry had that he had put out. And I went to a couple of courses at ASCRS and watched some of my friends give lectures on these topics. And ultimately, what it came down to was I made one of my fellow cornea colleagues who was not doing DMEC sit down in an OR with me. We got eye bank eyes. We had our little manual out. We practiced, injecting, and it really was a commitment from yourself to want to learn something, because we can talk ourselves out of anything. Oh, I don't have time to learn that. Oh, I don't want to, oh, I don't know. I can't find the right patient. It's all excuses. If you want to do something, you will make yourself do something. And I really think that with interventional mindset, some of the goal is to help to chip away at some of those barriers, like some of the pain points of starting something new, and maybe, shorten the learning curve. So lots of experts are going to be involved in sharing their wisdom. And I think that through the communal share of that information, it just makes it one step easier to adopt something new.
Nate, where do you see, when you look at the landscape, where do you see refractive cataract surgeons, maybe like myself, missing the boat on MIGS?
Well, I think part of it is dipping that toe in the water. I think that once most of us get in the space, we start to feel comfortable. you know, and then part of it is also, is your practice really geared to detect, diagnose glaucoma? Because, you know, glaucoma is something that can be tough to dabble in. But if you think of it right now, probably most of the new glaucoma is being diagnosed during cataract evaluations. So you bring a patient in, you want to take their cataract, but you're a MIG surgeon, and so you do maybe an OCT, and voila, you've helped the patient even more. So I think that's a motivating factor for people. You're not, you know, jumping on board to a previously diagnosed glaucoma patient's care. You're helping someone get a diagnosis. But I think, you know, then again, it's just finding that first technique that fits with your practice. And I think, you know, a lot of surgeons who are in the cataract refractive space are very nervous about complications, you know, and I think if I could compliment the work of one company, you know, I would say Glaukos, in particular with their eye stents, have done a very good job. They have very robust data. You can present that data to patients. I think Ivantis also, 5 years, you know, they're working on 5 years of follow-ups. You can, you know, show your patients how safe these procedures are, randomized prospective trials. That's the type of information that's really, you know, safe for patients, and just that confidence that this has been done in thousands of patients, and it's totally consistent with a refractive cataract surgery patient population. Knowing that you have that level of confidence in the technology, you know, is something that you can be proud to bring to patients and not have to worry about.
Yeah. So Preeya, tell us a little bit more about Interventional Mindset, the website, kind of what the vision is going to be going forward, and, you know, what you're most looking forward to in terms of this project.
Well, the website is interventionalmindset.com, and it will be a collection of digital content, videos, podcasts, and other didactics to really tackle some of these important topics. And I think through our conversation, you know, we've seen that there's actually a lot of interplay and overlap between ocular surface disease, cataract surgery, and glaucoma. Nate, even when you were just talking about, you know, the plethora of MIGS options, you know, I find myself thinking about, oh my gosh, this is just like treating MGD. There's so many treatment options, and how do you sort through those? And so the goal is to really help to bridge that knowledge gap, to get clinicians, and, you know, this is going to be applicable to anybody, you know, not just clinicians, but to really help to kind of take away those pain points and understand and learn how to adopt the new technologies. You know, we're all in the same boat, right? If there's something new, you know, I hear about MIGS and I'm like, ooh, I don't, you know, I don't know if I want to talk about that, you know, can we next topic? But you know what, I actually do want to, you know, develop and grow, and I'm sure there's tons of people out there that also have that same desire. You know, when we look at our practices now, you know, in the post COVID-19 era, we're able to see less patients in our clinics. We're at the point where we need to sort of maximize what we can do with the patients that we have. And I think that, you know, a lot of people are in that mindset now of wanting to grow and wanting to kind of expand the offerings in their practice. And so really, we want to be a resource for docs out there that are trying to become an interventionalist.
With that in mind, you know, we've talked about maybe issuing challenges to each other.
Yes, I have challenges for both of you.
Okay, I want to hear it.
Yeah. Okay, so Nate, since MIGS is basically similar to MGD in that there's so many options. I was just thinking that, seriously. I think that we should have our glaucoma doctor who creates all kinds of ocular surface disease. Rather than sending it to your cornea colleague down the street, I challenge you to actually adopt one of the procedures, and I'm happy to, you know, help you, teach you, you know, hold your hand through the process of learning MGD, but maybe, you know, doing some tear care treatments to treat the MGD that you're seeing with PGA use.
Challenge is accepted. And I do want you to know I haven't been referring out my surface disease. I've just been ignoring it.
Oh, perfect. Even better. Even
Much
better.
better, much better.
Even better. And Gary, you did do a lot of talking about MIGs, and I sort of feel like, at this point, you've talked about it. There's an interest. There's clearly, I sense the excuse list increasing one by one as I listen to you. So I'm thinking that Nate should teach you how to do Omni. What do you think?
I would be, all right, how about this? I will do Omni. I will do that if Nate, you can come and show me, and when you're here at my office, I'll teach you how to do LASIK.
That
Ooh.
sounds good. Yeah.
I mean, that would be pretty fantastic. And we'll probably have to video it and just show what happens, even if it's not great. Because I think the reality is we need to stop pretending like we're all perfect. When we give presentations on the podium, a lot of times we only are showing people, what we're really strong at. We don't show people how we struggle and the areas that we're not strong in. But I think it's time that, we surgeons who are maybe out there and maybe a little more visible, we're human, we're not great at things when we're learning. And I think it's okay to talk about that. And if we don't talk about that, I think that is one of the biggest barriers that prevents people from trying, because we're not going to be experts from day one. And it really is hard when you are an expert at what you do to feel like a novice. And that might be the biggest challenge to becoming, to really truly having an interventional mindset, I think.
Well said, Gary. So we're all coming to Kentucky.
Yes. Now, Nate, I think we need to challenge Preeya on something, but I feel like she's good at everything already. What should we challenge Preeya on?
Oh my goodness, guys.
I mean, how is your MIGS, Preeya? How are we doing there in that area?
So how about, just get me to do a few SLT, maybe,
Okay. All right.
like you, Gary, I used to do things like that.
Yeah. Okay. So SLT.
Or maybe, what, like actually, like secretly, I've been thinking about doing this. So maybe this will be the shove in the right direction for me. We have 17 glaucoma faculty members, and I get a lot of the glaucoma ocular surface disease referrals. And so, I've been meaning to take more of, not just, maybe recommending, but Durista has come out recently. And of course, SLT is, a fundamental therapy in lowering IOP to help people get off of medicine. So I for a while, I've been telling myself, you should just get back to doing SLT. But it's been a decade now, it turns out, since I last did my last SLT. And I have not put a Durista in yet. So, maybe that can be my challenge.
All right. Your challenge is start doing SLT first. And once you knock that off, then we'll get to challenge 2, which will be Durista. Does that sound good, Nate?
Yeah, it sounds great. And those are great interventions to start with. Yeah.
Okay. So this is how this podcast is going to go. This is a new project for all of us. As you can tell, we're all friends, and we're going to give each other the business from time to time, which is absolutely great. I'm looking forward to that. And if you have questions or comments, we want you to log on to interventionalmindset.com, and we're going to have a way for you to suggest subjects, to ask questions, to be, to really engage with us and the other faculty that will be on the website. So we want this to be interactive. This is really just a passion project out of Preeya's mind that Nate and I are so lucky to tag along with. And we hope that this is something that really moves the profession forward. So thank you all. Really appreciate being part of this. And until next time.
Thanks.
Thank you, Gary.
See ya.